Thank you everyone for joining, and for those who continue to join, welcome to the first quarterly CST rounds for 2026. My name is Sarah Shalhoub from Western University on behalf of the CST Transplant ID core group. We today have a fellow presenting. Very happy to have Faisal Ali is a second-year pediatric infectious diseases fellow at University of British Columbia, who completed medical school training at the University of Aberdeen, Scotland, followed by pediatric residency at UBC. He is supervised today by Dr. Hannah Mitchell, pediatric infectious diseases physician at BC Children's Hospital in Vancouver, who leads a longitudinal transplant infectious diseases program that provides pre- and post-transplant care for children with solid organ bone marrow transplant. Thank you so much for presenting, Faisal. Floor is yours.
No worries. Thank you, Dr. Shalhoub. So I think we'll get started. Um, so just before we start, I just wanted to make a land acknowledgement. So, I live and work in Vancouver, which is on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and the Tsleil-Waututh nations. And I know we're joined here from from people from many places across Canada. And I really invite you to take a moment to reflect on the Indigenous lands that you're on and the peoples who've cared for them. So we'll get started with our case. So our case is a 16-year-old female who underwent a kidney transplant in May of 2023 for steroid-resistant nephrotic syndrome, so focal segmental glomerulosclerosis, without an underlying genetic diagnosis. She received her kidney from a living, unrelated donor. And I'll just take you through kind of her course in the first few months after her kidney transplant, which was a bit rocky. And that a month after her kidney transplant, she developed an focal segmental glomerulosclerosis recurrence, which was treated with intensified immunosuppression. So intensified TAC, high dose PRED, Plex, and rituximab. Within kind of the end of that summer, she was in remission from that condition. Unfortunately, in the fall, in October of 2023, she developed another recurrence, and this was diagnosed on the basis of nephrotic range proteinuria. So again, she had intensified tacrolimus and high-dose pred that was slowly weaned, and she was in remission by early spring 2024. I will say that during that second recurrence, she did have a renal biopsy that did not show any evidence of rejection. Kind of eventually through to the spring, her tacrolimus targets were decreased and her steroids weaned ultimately to 5 milligrams once daily. And just kind of highlighting her immunosuppression, she was on a steroid-based immunosuppression regimen initially from the offset to reduce this risk of FSGS recurrence, so tacrolimus, MMF, and prednisone.
No. Faisal, may I ask what was the induction regimen?
I think it was standard induction regimen with basiliximab and steroids, and then she was also started on the MMF and tacrolimus.
Okay.
Just on a bit about her background pre-kidney transplant is that she was diagnosed with, as I said, steroid-resistant nephrotic syndrome in November of 2020, and she experienced a rapid deterioration in her kidney function through the next year. Her biopsy confirmed the FSGS, and she was started on peritoneal dialysis in December 2021, and ultimately got her kidney transplant, as we said, in May of 2023. She had various complications of CKD as well as adrenal insufficiency from her steroid use. There were no known allergies, and she was immunized apart from the seasonal immunizations. And I'm just going to move on briefly here to her social and exposure history, which is, of course, relevant when considering infections. So, lives on Vancouver Island, born in Canada, no real major travel history besides kind of local travel in the Pacific Northwest region. Enjoys a lot of kind of outdoor activities such as mountain biking and camping, and had a couple of pet cats, which were indoor outdoor cats, and some reptiles in her garden. One thing of relevance, which we see sometimes in our adolescent patients, was that she disclosed some recreational cannabis and nicotine use. All right, so moving on to the history of her presentation. So kind of a very long history of a few months, but essentially about 6 months prior to her presentation to hospital that we're going to talk about, she developed headaches. These headaches were described as intermittent, bilateral, frontal, with radiation to her ears and jaws. And from the previous slides, as you know, these symptoms were happening in parallel to her recurrence of FSGS, which was being managed as well. So her headache intensity was fluctuating, and one of the difficulties was that her symptoms were rather intermittent and were coming and going at different times. And some of these other symptoms included fatigue, nausea, dizziness, sleep issues, decreased appetite, tinnitus, photophobia, phonophobia, and some mood changes. At that time, there was various differentials, which included migraine, pseudotumor cerebri, some medication adverse effects, such as like her antihypertensives, I believe her ACE inhibitors, and the doses and agents that were used were actually adjusted. So through this time, she was actually admitted to hospital a couple times prior to kind of the main hospital admission that we'll talk about. So in the spring of 2024, she was admitted with a pre-renal AKI that improved with hydration. And she was kind of through this hospital admission, she was treated with a 2-week course of Amox and Amoxiclav for suspected upper respiratory tract infections. I will say at that time in April 2024, she did have blood cultures that were negative. She did have kind of baseline labs that showed a CRP of 15, a white blood cell count of 10 with a neutrophil count of 9. And then a month later, she was admitted to hospital again with significant weight loss. And in retrospect, during that hospital admission, she was noted to have had low mood and emotional lability since December of 2023, so the onset of her headaches. She was diagnosed with anxiety, depression, and an eating disorder and started on some psychiatric medication, so sertraline and quetiapine. Through this period, her headaches were actually fluctuating to the point where during some of the admissions, she had endorsed that her headaches had resolved. And this is just kind of in pediatrics, we always look at growth charts of our patients, pediatric and adolescent patients, and this just highlights kind of the degree of weight loss that she experienced in that time period. So you can see her weight had kind of drastically gone down more than 2 growth percentiles. So a couple weeks before her admission, she also started developing right eye swelling, proptosis, diplopia, and excessive swelling. Excessive tearing. Interestingly, her headaches had resolved at that time. So she was assessed by her primary care provider, and there was concerns, rightly so, of orbital cellulitis, and she was advised to present urgently to the emergency department. Just to highlight what medication she was on at this time. So she was on tacrolimus, MMF, and prednisone, and she was on, some other regular medications. And I want to take your attention to the antipsychotics, so quetiapine, antidepressant sertraline, and trazodone. Um, so she presented to the emergency department in July of 2024. So this was kind of about a bit longer, 6 or 7 months after her headaches had started, where she was afebrile and hemodynamically stable. She was noted to be quite agitated, tearful, and it was subsequently decided that she did not have the capacity to make medical decisions. An urgent CT of her head and orbits was done, and she was empirically started on antibiotics. Her CRP was noted to be elevated at 81. Um, so this is just a bit of a case summary up to now. It's that a 16-year-old female who's about a year post-kidney transplant with a 6-month history of headaches, low mood, emotional changes, and weight loss, diagnosed with anxiety, depression, and eating disorder, and now presenting with a 2-week history of query right orbital cellulitis. I think the next slide is a Slido question. So if you guys have your um, phones at hand, there's a QR code here that will take you to the link. But I just want to highlight that there's no right or wrong answers. I think the questions here just kind of highlight the complexity of the case. I will say that unfortunately, I wasn't able to embed the answers to the slides, so I'll kind of narrate them. But what do you guys think is the most likely cause? And these are some of the uh, infectious possibilities. I'll give it a few more seconds.
We can see the answers, Faisal.
Okay, great. So 45% mucormycosis, and then closely followed by bacterial cellulitis, aspergillosis. I'm going to move on now to the next slide. So this was the results of her CT head and orbits with contrast, and I don't think you need that yellow arrow to see kind of the finding of extensive invasive infection, likely of sinus origin, and that basically considerable frontal lobe edema that was highlighted by the radiologist. And in hindsight, thinking about her personality changes and anxiety and depression, whether the frontal lobe disease could obviously explain that. She was subsequently taken to the MRI suite right after, where she had an MRI of her head and orbits. And, you can see that mass in the frontal lobe there. And the as radiologist mentioned, suggestive of invasive rhino-orbital cerebral fungal sinusitis with extensive cerebritis and bifrontal vasogenic edema. So this brings us to our second question. So what would your next step in management be? Right. So we've got a lot of obviously urgent surgical consultation and some have been start empirical antifungal therapy as well. All right, I'll move on in the interest of time. So within the first day of her admission, she went to the OR, and it was a joint OR with the ENT, ophthalmology, and neurosurgical teams. I'm not going to read kind of all of that, but just to say this is kind of from the OR notes from the specialist, that there was a lot of granulation tissue, bony defect, a lot of necrotic tissue, um, some pus that was noted in her nasal passages. But all this to say that there wasn't much in the way of source control during this initial OR. So minimal source control. It was mainly done for sampling. And, very soon after we got results from the pathology and microbiology showing frozen sections demonstrating fungal hyphae. And the pathology report, which came in soon after, showed that it was mostly in keeping with Aspergillus species based on morphology, and microbiology was 1+ presumptive Aspergillus species. This is maybe a clue to which species it is, which we'll get to later on. And her diagnosis at that time was invasive rhino-orbital cerebral aspergillosis. So I just wanted to take a pause from the case and talk about some kind of M&M issues very briefly. About some things that, and hindsight is always 2020, but looking back, things that may have caused some delay in presentation and imaging. So when thinking about the broad category of why there was some diagnostic delay, we always think about things like anchoring bias, where chronic headaches, weight loss, and personality changes may be attributed to more benign or psychiatric causes. We think about the symptom fluctuation that she had, where her waxing and waning symptoms to the point where she was admitted a couple times to hospital with a resolution of her headaches, which reduced the urgency of investigation, as well as underweighting her immunosuppression as she was on kind of an altered immunosuppression regimen with high dose steroids that maybe was a bit underweighted. Systems failures is a strong word, and obviously hindsight is very different than being in it. But we think about some other things that may have contributed to this delay, which was transitions in her care that she was seen by multiple providers over those 6 months with competing priorities, where she was also being managed for FSGS recurrence. Cognitive load is something we see very commonplace where, we're working in busy clinical environments, and the rarity bias where there's a low prevalence of orbital cerebral invasive fungal infection in children or adolescents after renal transplant. Very briefly, invasive aspergillosis in children and in adolescents usually predominates, and I'm sure it's the same in adults with pulmonary disease, and dissemination to the central nervous system is less common. And Aspergillus fumigatus is the most common species. Some of the common predisposing conditions, I'm not going to go into them, but mainly bone marrow transplant, bone marrow failures. And when you think about SOT, you think about lung. We see a lot of inborn errors of immunity in children. One of the big ones is chronic granulomatous disease, and there's quite a high incidence rate in that. And that's why a lot of those patients are on itraconazole prophylaxis. And I just wanted to highlight this guideline by Dr. Hussein, the invasive aspergillosis and solid organ transplant recipients guidelines from the American Society of Transplant ID. And just it kind of building on the risk factors that are outlined in the previous slides, it just shows that the incidence of invasive aspergillosis post-kidney transplant is, relatively low at 0.3 to 4%, has a high mortality of 60% and a graft loss of 25%. And when we look at late invasive aspergillosis risk factors, over immunosuppression, high or prolonged steroids are some risk factors as well. All this to highlight that our patient had a bit of an unusual presentation in that, her underlying condition was a kidney transplant and the site was CNS as opposed to pulmonary. It's just going to go back to our case here. And this one is another question before we get into kind of the therapy that she was started on. So, which antifungal agent would you choose? And the answers don't actually ask you why, so maybe that could be a discussion point for the end. But which antifungal agent would you choose? I'll give it a few more seconds. All right. So I'm seeing the most answer was voriconazole plus liposomal amphotericin B. Yeah, at 70%. All right. So some considerations for our patient was that we wanted an agent that was CNS penetrating. We wanted an agent that was relatively renal sparing and had easily attainable therapeutic range, acknowledging that our patient was on some medications that will affect our drug getting to target. So namely tacrolimus, obviously, and also the antipsychotic quetiapine. So the patient was actually started on isavuconazole. And it certainly would not be considered first line in Canada. And we had a lot of discussions, and one consideration was lowering the dose of tacrolimus while on Vori, but knowing that that could add an additional layer of complexity with having to adjust the voriconazole dose to stay in target. And so ultimately, our decision kind of was based on a few different facets. So we kind of had various discussions within the ID team at our department, as well as speaking to world-renowned kind of PEDS-ID or mycologists. And we had ultimately decided based on that to go with isavuconazole. There was consideration for adding liposomal amphotericin B until our susceptibilities were known. However, kind of thinking that in a renal transplant patient with tenuous kind of kidney function, that may kind of limit the amphotericin B use. We wanted an agent that had CNS penetration, and we knew that we wanted to target higher levels, kind of at the CNS levels. We knew that we eventually wanted to do some kind of source control given this large frontal abscess, and we wanted an agent that, if susceptible and GI absorption was okay, we would be able to switch to an oral therapy as well. I will say, so during the time that this happened, this study came out at the same time. So the European study of cerebral aspergillosis treated with isavuconazole. And it commented on isavuconazole for CNS aspergillosis. Specifically, it also looked at 7 pediatric patients, albeit all of them were oncology patients. So it was a European multi-center retrospective study of patients treated with isavuconazole for proven or probable cerebral aspergillosis between 2014 to 2022. They enrolled 40 patients from 10 countries. And so isavuconazole was chosen as first-line therapy in 10 patients. It was primarily used in combination therapy and resulted in control of disease in 70%. The other group, so 30 patients, received isavuconazole after a median of 65 days on another therapy. The switch was mainly because of side effects or therapeutic failure and achieved control of disease in 73% of patients. And so when measured, isavuconazole levels were actually low in the CSF, but adequate in serum and brain tissue. And toxicity led to treatment interruption in just 7.5% of patients. 12-week mortality was 18%. And so based on this cohort of patients, isavuconazole appeared to be a well-tolerated treatment. And mortality for cerebral aspergillosis was seen kind of similar to that was reported with voriconazole. So we'll move on to our patient's hospital course. So just briefly, she had blood cultures that were negative. She had further imaging that didn't show any evidence of further dissemination. Her immunosuppression was adjusted in that her tacrolimus dose was adjusted down, and her MMF and prednisone were stopped. She was supported nutritionally given her significant weight loss by inserting a G tube for feeding. Um, I think it's important to note that there's a lot of considerations that came into play when reducing immunosuppression. And it was kind of a double risk because, weighing the risk versus benefits of obviously treating and controlling this infection, but also for underlying kidneys. While reducing immunosuppression means that an FSGS recurrence is more likely, and that will need steroid pulses or rituximab, knowing that graft rejection and graft loss was a possibility, and knowing that kind of a worsening kidney function in itself is immunosuppressive. So around this time, we got our isolate back, and it was identified as Aspergillus fumigatus. And you can see here some of the microbiological MICs and susceptibilities that were reported. So she was started on isavuconazole, but unfortunately, over the next 3 weeks, she developed worsening eye swelling, some proptosis and chemosis, and initially she was afebrile, but then became febrile. She was having, daily follow-ups with pediatric. She was under the pediatrics care, but with the surgeons, including the ophthalmologists, who were very closely monitoring her eyes. So at this time, liposomal amphotericin B was added, so in addition to the isavuconazole, and repeat imaging was obtained. So this was the repeat MRI, so about three weeks or so after her admission, and showed that there was mild interval increase in the overall dimensions of the rim enhancing material, with some bifrontal cerebritis and extensive bifrontal vasogenic edema. And so within the next few days after that image was obtained, she went for a second surgical intervention. This time it was more of a source control as opposed to just a diagnostic surgery. Again, it was by neurosurgery, ENT, and oculoplastics or ophthalmology, where she went for an endoscopic craniofacial resection and debridement of abscess. And from the OR note, they noted aggressive debridement of the necrotic and purulent material from the anterior fossa cavity, where portions of the capsule were removed, although significant capsule still remained. She had a reconstruction. Um, there was also some CSF leak, and so she had some reconstruction of kind of the base of her skull with fascia lata graft as well. So the pathology reports demonstrated necrosis and septate hyphae consistent with aspergillus. So their kind of impression was a fungal abscess. And again, the cultures grew Aspergillus fumigatus. So moving on kind of through her hospital course, which was rather prolonged, of course, but about a month or so into her hospital admission, so now we're into August of 2024. She was still having mood swings and was still deemed, not having capacity to make her own medical decisions. Um, we had done therapeutic drug monitoring for the isavuconazole, which was in the recommended range for CNS. And at that time, liposomal amphotericin B was discontinued, and she was back on isavuconazole monotherapy. So over the next couple of months, she continued to improve, receiving her nutritional rehabilitation. However, kind of at the 7 week mark, there was noted to be recurrence of fevers, a rising CRP, and this prompted a repeat MRI. At that point, the differential included whether this was disease progression versus a new infection. And so this was the MRI, and it. So I'll just show you here the report. So it just showed a new basal frontal lobe brain herniation with a slight interval increase in the size of the anterior cranial fossa collection component with worsening bifrontal lobe vasogenic edema. And I will say that this herniation from the surgical defect, kind of talking about the graft that was placed during the previous surgery, was expected. And so it wasn't thought that she had have unexposed brain herniating towards the nasal cavity. So at that point, given the kind of progression on MRI as well as her symptoms, isavuconazole was discontinued and she was started on intravenous voriconazole as well as liposomal amphotericin B to bridge. She started developing drainage of purulent fluid from her right eye and had an emergency OR by ophthalmology for incision and drainage, where they cultured some of that pus and grew Aspergillus fumigatus as well. Over the next 3 weeks, we had some difficulty achieving therapeutic voriconazole levels. Uh, we basically maximized the dose, closely monitoring for potential drug-drug interactions, and did not get anywhere near the recommended target range. At that point, voriconazole and liposomal amphotericin B were discontinued, and she was restarted on isavuconazole. Caspofungin was added very briefly as salvage therapy for a week or so prior to being discontinued because of the following slide. So at this point in her hospital admissions, there were several MDT discussions. So with the surgeons, the medical teams, as well as the palliative care teams. So in terms of the discussions with the neurosurgical teams, in their opinion, the imaging findings, her symptoms with recurrence of fevers, elevated CRP, and worsening swelling was consistent with disease progression, and additional surgical intervention would mean partial removal of the frontal lobe and significant damage to the eye with possible vision loss. The palliative care team was involved pretty early on in her hospital admission. Um, and ultimately, during one of the serious illness conversations, it was thought that she was having ongoing disease progression despite optimal management, labeled with a life-limiting disease, and was expected to unfortunately pass away in the coming weeks and months from neurological complications. At this time, there was discharge planning happening. Over the next few weeks, her CRP actually started to decline. Her mental status improved with less emotional ability and fewer mood swings. And she was deemed to have enough insight herself to talk to the palliative care team over those coming weeks and understand that her disease was considered not currently curable. Her kidney function remained stable with no recurrence of proteinuria or FSGS. Um, and, as discharge was being prepared, she had been labeled as having a life-limiting illness, and her goals of care had been established accordingly. So minimal medical interventions, no routine kind of transplant labs, no repeat imaging, and a focus on comfort care. She was discharged home on isavuconazole monotherapy. I know I went through quite a journey in terms of her antifungals, and I don't know if this is going to be any clearer, but this is just a bit of a summary of which antifungals she received in hospital. So if you recall, in July, in her first couple of weeks of admission, she was on isavuconazole monotherapy. With her first MRI, it showed worsening, and during her kind of definitive or her source control procedure, liposomal amphotericin B was added. After achieving target isavuconazole levels, that was stopped, and she was on it for a couple of months. And then with her second MRI that showed the interval progression, things were switched to VORI and liposomal amphotericin B as a bridge. When we couldn't achieve our adequate voriconazole levels despite maximal dosage, she was briefly switched to isavuconazole and caspofungin for about a week as salvage therapy. But after those decisions with the MDT team, including kind of shifting of goals of care, that was later switched to isavuconazole monotherapy, for which she was discharged on. Her immunosuppression, just a very broad strokes summary. She was just on tacrolimus essentially. The PRED had been discontinued early on in her hospital course, as was the MMF. So just a bit of a summary of her hospital course. So 16-year-old female post-kidney transplant, which she was hospitalized for 4 months for rhino-orbital cerebral aspergillosis. Species was fumigatus. She was treated with multiple antifungal agents with isavuconazole as the primary agent due to difficulty achieving VORI levels. She underwent 2 surgical procedures. I guess there was also the ophthalmology IND at the end. Her symptoms did gradually improve. There was a few hiccups in the middle there, but over the last few weeks of her hospital admissions, she had a gradual improvement of her symptoms, reduction of her immunosuppression, and nutritional rehabilitation. At the time of discharge, her prognosis was guarded. So I might briefly go over these slides in the interest of time, but essentially, the cornerstone of multidisciplinary management for cerebral aspergillosis is surgery, um, and it is an independent prognostic factor for survival in a lot of studies. And it just goes to highlight whether, are the patients who are fit for surgery initially healthier at baseline, and the benefit is generally attributed to decreased fungal burden and removal of the avascular necrotic tissue into which systemic antifungals penetrate poorly. Um, Literature is somewhat divided. Some reports suggest that surgical delay of more than 6 days has been associated with decreased survivals, while others found no difference regardless of whether surgery was performed between days 1 and 30 after diagnosis. Obviously, reducing immunosuppression is a cornerstone of management, and then some of the antifungals that we think about include voriconazole, if mucormycosis is ruled out, and these are just some of the um, considerations that need to be taken when thinking about using voriconazole. It does have good CNS penetration, but we always think about the narrow therapeutic window and the difficulty in terms of achieving those therapeutic windows, particularly given the drug-drug interactions. It also has quite a large side effect profile, of course. Isavuconazole, which was our primary agent of choice, also has good CNS penetration. It's typically reserved for patients who are intolerant to voriconazole. There is some therapeutic drug monitoring, as we saw in our patient, and it had been shown to be non-inferior to VORI in RCT data with fewer toxicities. It is available IV and PO as well. This is a bit of an older paper from the Lancet, which was isavuconazole versus voriconazole for primary treatment of invasive mold disease, an RCT in 2016. So it was a phase 3 double-blind global multicenter comparative group study, which enrolled 527 adult patients. between March 2007 and 2013, and it was powered for non-inferiority. And as you can see from the key results, isavuconazole was non-inferior to voriconazole, and mortality at day 42 is the same between groups. Some other fungal agents that we think about is liposomal ampho-B, empiric or if intolerant to voriconazole, posaconazole as well, which is an oral option um, that can sometimes be used as well. And caspofungin is not recommended as monotherapy, just considered dual therapy for salvage situations. Something we obviously thought about at the start was the possibility of azole-resistant Aspergillus fumigatus, and just kind of highlighting this study from um, looking at azole-based fungicides in agriculture, which are more prevalent in Europe as opposed to North America, and hence kind of rates of resistance there are higher than what we see in North America. And thinking about that, if you're worried about resistance, then liposomal amphotericin B would be an agent of choice. So I'll take us back to our patient here. So her post-discharge course, she was remarkably doing well. So about 2 or 3 months after discharge, she was noted to have normalization of her mood and behavior and was noted to be back to her baseline. Her goals of care were revisited. Her labs were done and showed stable kidney function with no evidence of FSGS recurrence. She continued on isavuconazole, and given these changes in MRI, which originally was planned to be repeated. And so this is a repeat MRI that was done 9 months after her diagnosis and about 5 months after her discharge. This was her first MRI that was done since discharge. And so it showed marked interval improvement in the bilateral fronto-basal rhino-orbital intracranial fungal disease with reduction in the volume of the abscess essentially and restriction necrotic fungal elements, and resolution of the extensive edema within the frontal lobe. So you can see that kind of significantly smaller than the last MRI I showed you. So just another question. So when would you repeat imaging after kind of this new information where um, she started doing better post-discharge with improvement in her last MRI? Give it a few seconds. Again, there's no right or wrong answer, of course, just hoping to stimulate some discussion. So I've got 57% with repeat MRI every 2 to 3 months until radiographic resolution, closely followed by repeat MRI as guided by clinical course and goals of care. Seem to be a tie for those two. Okay. So she did end up having some serial MRIs every couple of months, which showed stable findings. Her psychiatric medications were discontinued, and her BMI actually improved up to 21. And she was noted to be living her best life in that she was, you know, um, nearing the end of her high school, planning on learning how to drive and getting a driving license, and also thinking about future plans. So intensification of her immunosuppression was actually carefully reintroduced. So MMF was started at half of her target range. This would have been in June of 2025. So this was about 12 months after initial diagnosis, um, based on results of renal biopsy, which had been showing some inflammation and concerns of borderline rejection. This was increased to a full dose in the following months as imaging continued to be stable. She was not restarted on steroids. In October of 2025, so this would have been um, 12 plus 3, 15 months after her diagnosis. She was switched from isavuconazole to posaconazole, as there was no kind of special access funding to continue to fund the isavuconazole at that time. Considerations for posaconazole was, although there is less data for posaconazole in CNS aspergillosis, it does tend to have some CNS coverage and penetration. And the thought was that it was reasonable to switch this far into her illness course with stable radiographic imaging. Levels were done 2 weeks after initiation of therapy and were within targets. And she ended up having a further repeat MRI in December of 2025, so 18 months after diagnosis. This was her last MRI so far. And it essentially showed no interval change, essentially, just slightly improved diffusion restriction of the residual nodules. At this point, when she did this MRI, it was about 18 months into her antifungal therapy. So I believe this is our last Slido question. So um, kind of what are some thoughts regarding the ultimate duration of therapy now that we're about 18 months in and we've had clinical improvement as well as stability in imaging findings over the past serial MRIs? All right, so I've got kind of mainly two options. So treat until radiographic stability as well as treat until complete radiographic resolution. And yeah, as we know, there's obviously no fixed duration for invasive aspergillosis involving the CNS or orbit. So, all right. And so her plan right now, as of kind of the last visit, was to continue her posaconazole, repeat her MRI in about 3 months, which would be, approaching this month or so, or this period, and consider discontinuing antifungals once radiographic stability is achieved in discussion with obviously her overall MDT team. There's a potential for an elective transcranial endoscopic repair of her anterior cranial fossa floor with neurosurgery that may occur in the coming months as well. Just kind of in the last few minutes, going through some literature of invasive aspergillosis with kind of a sinusitis with orbital cranial extension. This was a retrospective case series out of Saudi Arabia between 2000 and 2012, where they enrolled 12 patients. Kind of the youngest were adolescents up to the age of 50 years old. There weren't any solid organ transplant patients. It was mostly diabetic patients. And, they had very similar presenting symptoms with chronic headaches, nasal obstruction, as well as some visual symptoms. And just to highlight that the patients in this case series received liposomal ampho-B for the first 2 weeks, and then were stepped down to either itraconazole. Most of the patients are voriconazole, and the total antifungal duration varied from the short end of 3 months to more than 12 months, and the length was guided by radiographic improvement as well as clinical response, and all patients underwent surgery. And the patients were followed up clinically and radiologically for an average of 36 months, with disease eradication achieved in 8 of those patients, so 67% of them. One interesting thing that came up, kind of final thoughts before we leave time for discussion, was the link between cannabis and aspergillosis. Our patient had disclosed that she did smoke cannabis regularly, and obviously it's impossible to definitively prove the link between marijuana smoking and aspergillosis, as especially in BC and on Vancouver Island, environmental molds are really everywhere, and we have higher rates of invasive mold infections in our very immunocompromised patients in BC than kind of other parts of Canada. But our the transplant team does counsel adolescents about the risk of aspergillosis with smoking cannabis. And we can see a couple of studies. This one's a bit older and it's in HIV patients from 1999, which basically had patients who had sino-orbital aspergillosis. And so 5 patients, and 3 of those patients had a history of frequent marijuana smoking. And this one is more well newer. It's from October 2025, and it was from the Chest Journal and looked at how aspergillus can contaminate cannabis, especially joints, vaping product, or improperly stored material. And the one of the clinical takeaways was advising high-risk patients on the risks of aspergillosis and symptomatic cannabis users. Um, This is more of a broad, honestly, consideration for pediatric patients is that knowing that our patient is obviously 16, so behaving more of an adult, but as pediatricians, we always think about some considerations for our patient population, knowing that the clinical presentations and imaging findings can be a lot more specific, a lot less specific than in adults, and we often have challenges obtaining specimens. And our patients display differences in the clearance of antifungal azoles with high inter-individual variability, and our target levels are not really validated in pediatrics. The use of suspensions rather than pills, particularly in younger kids, can make absorption less reliable. That was, I think, everything that I had just at the 50-minute mark. So I just wanted to acknowledge Dr. Hannah Mitchell. Thank you so much for your mentorship, guidance, and feedback through kind of preparing and this presentation and going through it. And I I had a couple of points for discussion, but Dr. Shalhoub, I'll just open it to the floor if anyone had any comments or questions to myself or to Dr. Mitchell.
Thanks, Faisal. This was really nicely done. You mentioned something about peds. What I recall from fellowship years ago is that peds tend to hypermetabolize azoles, and I think this really changes by age. The younger they are, the more rapid the azole metabolism is, and that's usually factored in when you guys calculate the dose. At what point does it do they usually get dosed like adults? Like at the age of 16, is that still a concern?
I think at the age of 16, we would probably err more on the side of them having more of an adult physiology, but I'm not entirely sure. I don't know if Dr. Mitchell, you have any more experience with that.
No, I mean, like with everything in pediatrics, we use weight-based dosing, and we do notice, especially in younger children, sort of in the under 5 range, where also the children who need suspension, right, if they're on oral medication, that is quite difficult to get in the target range. So, for example, posaconazole, which in older children or in adults is so easy, right? Like you usually give them, they're on the same dose and they stay within target. We oftentimes have a hard time getting them anywhere near the target. Why we had so many problems with voriconazole in this particular patient, I'm not sure. But kind of, I think once they're sort of adult weight and kind of like, mid to late teens, we would essentially treat them as an adult.
Thank you.
Do we have any questions? Thank you for that. Do we have any questions from the audience? Dima?
Thank you. That was a great presentation. I mean, one thing that I put in the chat, around 6 to 8 weeks when the imaging got worse, but eventually the patient got discharged. It could be that it's not the fungus that was getting worse, but actually immune reconstitution, right? And sometimes during when, like, luckily your patient did not progress, but sometimes you might need to give them steroids similar to the HIV patients or like your hematology patient when their neutrophil recovers, and that might be why like imaging got worse, but the patient continued to do well.
Yeah.
Agree, especially in hindsight. I don't think we were brave enough to give steroids. I will say that around the same time, at least from the ocular side, she literally had hyphae growing out of her eye, as reported in the OR. So I think there was definitely an element of disease progression, although some of the CNS findings may have been better explained by iris. And as Faisal has alluded to, I think it was this very complex multidisciplinary discussion around prognosis with parents and a young woman who at that time kind of did not have enough insight to actually be able to understand what was going on, which kind of, I think, made that kind of evolving diagnosis and discussions around care really challenging.
Dr. Hussein.
Great presentation, Faisal. I'm happy for the patient. So the good outcome. That will go more with Iris, in my opinion, also than worsening of the disease. And I think you guys did an excellent job in terms of managing this patient. When you gave a crew of Vancouver Island, the thing that I was thinking was Cryptococcus cantii or Cryptococcus neoformis, but the presentation was not typical for that. One question that I have is why initially it was just a diagnostic? Why didn't we surgically debride it or had an aggressive surgery to cut down the fungal burden? Though this is typically done in case of mucor, but with CNS involvement, probably that is a strategy that we need to employ as well with other fungi.
Yeah, no, that's a great point, Dr. Hussein. I think there's a lot of discussions with the wider surgical team at our institution, and I think it was deemed there may have been some morbidity with kind of approaching it with a craniotomy or a burr hole, and ultimately she was actually transferred to a different hospital for her like an adult hospital for her second operation, which I think they were more kind of comfortable or familiar with such cases. I think that was my impression of things, Dr. Mitchell, from reviewing.
Yeah, I think it was kind of a joint adult pediatric neuro-oculoplastics, if that's a profession, intervention. And like Faisal showed on the first slides, there was so much kind of thick granulation tissue that was just not accessible without kind of, like you said, craniotomy, is sort of a very invasive procedure. So kind of after, I'd say, much advocacy from the ID team, including Faisal, who at that time I will point out was in his first month of ID fellowship. We sort of convinced them to get back for the second OR, and they sort of, debrided what they thought was reasonably safe, but kind of, as you saw from follow-up imaging, I think even accounting for iris, there was definitely still a lot of disease left. So it was one of those situations where, ID was pushing for source control appropriately. So surgeons said that we should be continuing with antifungals, and there was actually not a whole lot more they could do, unless they did an open scalp surgery and removed part of her frontal lobe.
One other comment that I'll have is in patients who are rapid metabolizers, especially with voriconazole, we have used cimetidine with the voriconazole to achieve the therapeutic drug levels. And we have been able to achieve therapeutic drug levels. So this is something to keep in mind. Bore is equal to ISA, ISA is equal to POSA, so all three are equal. A is equal to B, B is equal to C, so A is equal to C. But the data with POSA is not great, and it penetrates more in the tissue. I'm not sure it does penetrate really well in the CNS because there's less vascular tissue. So given a choice, I would have probably kept her on isavuconazole. But she's being followed, so we'll get to hear about her sometime.
So is the plan now to stop? I may have missed it, but is the plan now to stop the antifungals and just get another MRI in 2 or 3 months, or what are you guys thinking?
No, she's still on the posaconazole. I think she's going to get a repeat MRI this month
Okay.
and kind of see her in clinic, see how she's doing, and also obviously with the MRI, and then make a decision at that point whether we're going to continue or discontinue therapy. That was my impression of the plan moving forward.
Would like the hyperintensity on MRI affect your decision, Hannah?
Kind of like the kind of change in the hyperintensity signal over time. it's so hard, right? Because I think a lot of this is kind of residual post-inflammatory changes. So if you ask me right now, I'd say no, not necessarily this far out. I think we'll probably wait also to hear from neurosurgery because she was potentially going for the flap reconstruction. So just in the interest of sort of just changing one thing at a time, we'll make sure that we have a good run on a background full immunosuppression, which is non-MMF tacro, sort of continuing stable imaging and that conversation with neurosurgery. And then I might give my adult ID colleagues a call since we are also transitioning her to adult care and discussion stop.
Would be interested in getting an update. Dima?
I'm just going to add to the subject. I mean, we've had few cases with CNS fungal disease, and it takes forever for the images to become normal. And so after a prolonged time, we have actually stopped, even if they were still getting better. And then you can repeat an MRI few months after to make sure that nothing gets worse. I mean, she's had 18 months of treatment, and I'm not sure how much POSA is doing a CNS penetration. I mean, I don't know if what can help you. I mean, there's some data with PET imaging when it's like in the chest. So I don't know if a PET brain would be helpful in also helping you decide when to stop.
Yeah, I think I would call like the nuclear medicine person on that one because yeah, I was thinking the same thing. Like, is it burnt out disease or is it still active? But yeah, that would be interesting to explore.